So the next, yeah, thank you very much, Dr. So the next one would be in Myanmar. The presenter will be Dr. Ni Tun from Medical Action Myanmar and Myanmar Oxford Clinical Research Unit. Her research project is about opportunistic infection. The title is, Can we safely stop the secondary prophylaxis of Talaromycosis infection in HIV-infected patients? Welcome, Dr. Nini.
Thank you for welcoming me. And good morning, everybody. And thanks a lot for HIV-NAT 2020 for giving us this chance to share our experiences here today. So I'm going to talk about how can we safely stop the secondary prophylaxis in the patient who has Talaromycosis infection. So I think this infection is not very new for almost all of us from Southeast Asia region, because this fungal infection is quite common in our region. So first going to seeing this endemicity of the infection. So my country is here. And the first penicilliosis, or I'm a little bit used to it, penicilliosis, because I was trained as earlier time. So the first case I have seen penicilliosis is in the northern Shan state in 2004. The first patient came into my room when I was working with Medicine Sans Frontier Holland. And the patient came with a skin pupule. I will show later the slides. And then the whole village put him outside the village because they thought this is the blood magic disease. Somebody made it happen because he's a naughty boy from the village. So that is the area that I've seen the first case of penicilliosis. So it is, which many of you already knew that, it is very important, age-defining infection, but nowadays, thanks to ARD, because we are seeing less and less penicilliosis patient, it's a very important cause of death in the patient with AIDS syndrome in Southeast Asia region. And it is actually, it's not only the skin, but this is the skin as we have seen in the patient. It's not only in the skin, it's a disseminated infection. It's go to multiple organs in your body. So it's go to these, the whole body symptoms, which is patient will come to you with fever, weight loss, anemia, hepatosplenomegaly, and respiratory, GI, and lymphadenopathy. So patient can come with all these very vague symptoms to you. So these are a few skin lesions. So you will see like with the central amplification, and sometimes you will see some necrosis. So the main issue here is, so it is a late manifestation. So when a patient came to you, like I mentioned before, with skin, hepatosplenomegaly, and fever, hepatosplenomegaly, and anemia, we don't know what is what. And then, because without diagnosis limitation, with the diagnosis limitation, we do not know what is it. But then the thing is, it is absent in 60% of the penicilliosis patients, so which is the main important clinical feature actually. So how are we going to diagnose? This is we did in our setting. Or what we did is we do the skin split smear, and we send for the gene stain, and we see the fiction acceptation of the fungus. So, but we can do, if you don't see the skin papules, I have done before biopsy and sent to the laboratory. So you can also do skin biopsy and culture or bone marrow biopsy. If you have a facility, you can also do PCR, but ELISA is a bit of in the process, but it's not really confirmed yet. Well, I'm talking, this is a kind of theory, but we are doing only this in our setting. So a culture, of course, it yields the highest positivity if you do it from bone marrow and then follow on skin and the blood. So this is a kind of diagnosis, what we are doing in our setting. So the good thing of this is you get the diagnosis very quick, so you can start treatment straight away without delay, which is very important for life survival. So the treatment-wise, what we are doing in our setting is amphotericin, first 2-week infusion, and then followed by high-dose itraconazole. And then 8 to 10 weeks, then we follow with the secondary prophylaxis. So my study, I'm going to highlight about importance of secondary prophylaxis after the patient get infected with the Talaromycosis infection. So in the more rich setting, they use liposomal amphotericin, which we hopefully in future we can use it if Global Fund gave too many to us. But earlier time in 2004, we didn't have itraconazole even. So what we used is that my first patient in Shan State, I used fluconazole high dose and he get better. So which is 2004, which is kind of very early time. But now we are not in that state anymore. So I want to highlight a little bit about relapse. So relapse is very high. So the optimal duration is quite unclear because there is no randomized controlled trial study and it's not really intervention study about when to start secondary prophylaxis in your AIDS patient when they take ARD. So, but there are quite a number of studies actually from Thailand. It's all about retrospective analysis or small cohort. So this mine cohort is also small cohort. So I believe that data will combine these global data and will support the evidence to get stronger. So that's the reason why I decided to do analysis of the stopping of itraconazole. So in my cohort, actually, with the medical action in Myanmar, we have less patients than MSF. So we have like altogether, during my analysis, I look at the 5,400 HIV patients, but among registered between 2009 and 2017, we have diagnosed and treated 46. Which here I like to a little bit mention about the clinic area. The clinic is from Yangon, which is capital, suburban area. It's not in the northern Shan State, so you can see the prevalence here. And so among 46 patients and 39, which is 85%, has the skin smear. So you can see here how many penicillosis maybe I might have mixed because it's only 60% of patients have the skin papule, plus they are already very sick. So maybe I might have missed a lot of patients who doesn't have the skin papule. So these are the same baseline characteristics of 46 patients altogether. 53% are male. CD4 is very low, 24. And then they kind of 63% of them diagnosed as penicillosis before ARD. Excuse my penicillosis. I'm a little bit used to calling penicillosis in compared with Talaromycosis. And so interesting enough, almost everybody has anemia, and 85% have umbilicated skin papules, and they have 65% have hepatosplenomegaly, which is a bit vague. You can have hepatosplenomegaly by HIV itself, so it's a bit kind of not really clear. So median temperature is 38 degrees Celsius, and here is 67. Yeah, so this is I want to highlight here clinical importance of this. So 67% of patients who we diagnose as a Talaromycosis already have TB. So they have a TB treatment. They already have TB treatment. So we look at the treatment outcomes. So 72% recover, 20% die, and median time to death is 106 days. So it's not very surprising because disseminated Talaromycosis itself is fatal if you don't treat it. Even if you have a treatment, the fatality rate worldwide is 10 to 30%, so it's pretty high. So we follow up this 25 patient who has stopped secondary prophylaxis of itraconazole. 0 patient experience relapse. So our median time of kind of follow-up is like % year is 75.2. Median follow-up all patient by years, median follow-up for all patient was 2.9 years. So this is our observation point. Our finding, what do we help to support literature? So our finding, I hope we contribute to the mounting evidence, the existing mounting evidence that secondary prophylaxis, you can be discontinued safely after patient is immunologically reconstituted. So I hope that data will add up the global data and help to make the guidelines stronger. Thanks for listening.
Thank you for your presentation on important opportunistic infection that is relevant to this region that we have a lot of Talaromycosis in Asia. So for the clarification, can you tell us a little bit more about what is the criteria to discontinue secondary prophylaxis in your settings? So you use time after ART or you use CD4 guided as a criteria to discontinue secondary prophylaxis?
Yeah, thanks for the question. Our criteria is patient has to be on ART and at least, we decided here 1 year, but in the guideline they say you can also look at the 6-man CD4. So, but in our cohort, our criteria is we look at the patient 1 year after ART, and then CD4 is above 100. Now, in addition to that, thanks to a gene experiment machine, we did a viral load suppress, and CD4 is more than 100, and we stop. So that's our criteria.
Thank you. Any questions or comments, or would you like to share your experience in opportunistic infection, secondary prophylaxis, discontinuation? Because I know that some settings we cannot use frequent CD4, so maybe sometimes we cannot use CD4 guided criteria, and maybe we use the time after ART to estimate time of CD4 recover. Might be another practical approach that we can use in this region. So if no more questions, thank you very much for your nice presentation.
Thank you. Thanks.